Today, I will be discussing whether acute inflammation is associated with lower muscular strength, mass, and functional dependence in male hospitalised older patients. According to the Australian Institute of Health and Welfare, hospital admissions of older adults have more than doubled within the last decade. The main cause for these hospitalisations often include falls, loss of muscular strength and mass, dementia, and reduced functional ability to perform daily living activities, also known as ADLs. Physiologically, older patients have less capabilities than younger people, and so small reductions in muscular strength and functional ability often have a significant influence on their living situations and overall independence. Previous cross-sectional and longitudinal studies have shown that low-grade chronic systemic inflammation is associated with low muscular strength and physical function. This study was aimed to determine whether acute inflammation has a catabolic effect in skeletal muscle metabolism. It is indicated by the C-reactive protein, also known as CRP, associated with muscular strength, mass, and functional dependency in hospitalized older patients. The C-reactive protein is a protein made by the liver and secreted into the blood. It is often the first sign of inflammation or infection within the body. The main methods used was an observational inception cohort study which saw the evaluation of muscle parameters in a prospective cohort of older patients at a clinical ward exploring relations with bed rest and malnutrition. This included a total of 378 hospitalized patients aged 70 years or older. Approximately 50% of the total number of patients had their C-reactive protein measured during the initial hospital assessment. Following assessments included the use of handheld dynamometry to measure the maximum isometric strength of the hand and forearm muscles, as well as bioelectrical impedance analysis to measure muscular mass. Everyday living activities, such as answering the phone and doing laundry, were assessed using the CAT score, ranging from 0 to 6 points, with a high score insinuating a greater level of independence. These ADL scores were separated into dependent and independent scores. The Lorden and Brody scale was also utilised to assess the instrumental ADL dependency with a score ranging between 0 to 8 points. The changes in ADL and IADL were identified as the 3-month post-discharge score minus the initial admission score. Linear regression analysis was also used to measure the association between the C-reactive protein, muscular strength, and muscular mass. Categorical dummy variables were used for the C-reactive protein and their respective severities. These associations were adjusted for comorbidities and age. Logistical regression was also used in measuring the association between the C-reactive protein, ADL, and IADL dependency, with the same adjustments made in regards to the comorbidities and ages. The results revealed that at the 3-month post-discharge mark, males with elevated CRP were more likely to be ADL dependent than those with normal CRP or no CRP measured at all. In females, no associations were found between CRP and muscular strength, mass, ADL, or IADL. In conclusion, hospitalized older male patients with acute inflammation had significantly lower muscular strength on admission and discharge, significantly lower muscular mass on admission, and significantly increased ADL dependency at the 3 months post-discharge mark. In females, acute inflammation was associated with lower muscular strength when discharged. As a result, this has implicated the targeted rehabilitation follow-up with patients suffering from acute inflammation to optimize their muscular strength, mass, and restore their pre-morbid level of function. In the future, longitudinal studies would be necessary to assess the course of muscular strength and muscular mass following acute inflammation in the short and medium term following discharge. Thank you.